have a conversation with Dr. Jen Gunter. She is a gynecologist, OBGYN in Kaiser, Northern California, and she's been in the U.S. for a few decades. Uh, she has two New York Times best-selling books. That's a big accomplishment on top of her career. She has a blog, Vagenda, The Vagenda, which is phenomenal on Substack. And she's out there as one of the great truth tellers in medicine, in particular, in this topic. She's been my go-to source for years. So welcome, Jen.
Thank you. Thank you so much for having me.
Oh, this is really a delight. And so I thought we'd start because just 2 weeks ago was a big day in the world of MHT. And this was when there was a Wall Street Journal editorial by Marty Makary, the FDA commissioner, and also simultaneously a JAMA paper. Um, and so I just was going to start by reading. Obviously, it was a big deal to have the black box from 2003 taken away, but there were a couple of statements I wanted to get your reaction to. The first was in the Liberation editorial that Marty wrote. He said, in my professional opinion, the demonization of hormone replacement therapy for perimenopausal women and the underappreciation of its health benefits ranks among the greatest mistakes of modern medicine. And then the other one in JAMA, which is kind of in the same uh, genre, with the exception of antibiotics and vaccines, there may be no medication in the modern world that can improve the health outcomes of older women on a population level more than hormone therapy. What did you think about that?
Well, I would say that Marty Makary is an incredible cherry picker and really displays a lack of breadth of knowledge of women's healthcare in general, or I would say even like healthcare in general. Because, if the data were that clear, if it was that thing, why do all the professional societies who have people who do the research and who have, you know, combed through everything and disclosed their biases, why do they have different conclusions? And so I think that was just propaganda. And primarily it seemed like it was based on the book chapter he wrote, which it was, again, cherry picked with, data from low quality studies. And in the press release and in the JAMA article, I mean, they referenced pre-WHI data,
Yeah.
a 1980 clinical, not even a clinical trial, a 1980 case control study, a 1996 case control study from a retirement community in Southern California, and then a review article from like 1991 of observational data. So I'm like, dude, if that's what you think is like the state of the art, like, let me introduce you to a lot more stuff.
Yeah. So speaking of stuff, there were two trials in WHI. One, of course, was with the combination, and then the other, smaller but still, I think, important, 10,700 women randomized to estrogen alone versus placebo. And they had very different results, whereby you say, is this the estrogen? Is it the hit of the dual hormone? How did you interpret all that?
Yeah, well, so as somebody who was practicing menopause care before the WHI and after the WHI, and whose care really has not changed at all, I would say that the Women's Health Initiative gave us a lot of information. It was, I would say, misconstrued by the press at the beginning based on a bad press release, which is really ironic because that's exactly what Makary did, right? So he is doing exactly what he accused the WHI researchers of doing. And I would say that, the WHI has given us a lot of data about two hormone regimens. So one estrogen, so conjugated equine estrogens, which is an oral form, and about conjugated equine estrogens with medroxyprogesterone acetate, which are regimens that we don't use much now. And we generally favor transdermal therapy. So it's very difficult for us to make kind of class-based decisions on one formulation, right? But I would say that what the way I would summarize the WHI app for everybody is this is really great evidence that hormones aren't going to hurt you. And it's also really great evidence that they're not going to make you live forever. And so if you need them for symptoms, then yeah, you should take them for symptoms. If they're good for you if you're at high risk for osteoporosis, then they're a very acceptable alternative for that. But we don't have this data on reduction of all-cause mortality or reducing heart disease or reducing dementia. When we look at the estrogen-only trial alone, the Premarin arm, after the initial trial was ended, we did see this emergence of a reduced incidence of breast cancer risk and mortality with combined equine estrogens alone. But people have to remember it's a very unique drug. It's got selective estrogen receptor modulators in it. And so it's not the same as giving somebody estradiol. And so that's a really interesting finding for conjugated equine estrogens. And that might be an indication for, a very, very specific use of that drug for people at higher risk of breast cancer. We might say maybe that's going to be a better alternative for you. But I just think it's important that it's, two regimens that we don't use now and that we don't see sort of the claimed benefits that the McCary is making from that trial.
Right. No, it's very clear from both the JAMA and the Wall Street Journal article, as you said, these were picking specific interpretations of, ice pick views of certain data, like the cognitive benefit and whatnot. But the other thing, of course, that the WHI enrolled older women, well beyond the average age of menopause, 51, I guess, and they could have been more than 10 years out. So you just wonder in this population back from 20 years ago, they reported on 20 plus 22, 23 years ago, that they were picking on a study that this was preventive treatment rather than symptomatic treatment, and the wrong women.
Well, I would say no, they're not
Okay.
the wrong women. So the WHI was designed to answer the question, can menopause hormone therapy reduce the incidence of cardiovascular disease and not increase the risk of breast cancer? Basically, like that's the summary of it. Because at the time, and as somebody who was practicing at the time, we believed that we could give menopause hormone therapy to women in their 50s, 60s, 70s, and even 80s and reduce their risk of heart disease. So people were doing that. People were prescribing it to 75-year-olds for heart disease. So this trial was designed to answer the question, should we be doing that? And so it's very easy for us to go back and sort of say, well, they're the wrong women, but that was what it was designed to do because that's what people were doing.
Yeah.
And, it was designed for everybody to be after menopause, because if you give people who are still menstruating hormones, you're going to make them bleed irregularly. And now you've unblinded your study, right? So you needed to get people who were at least a year post-menopause. So you weren't going to, be causing bleeding, but also they ideally wanted people who didn't have hot flashes. So they're a very small percentage of those, because if you're taking a drug and all of a sudden your hot flashes go away, you're gonna be like, well, maybe I was getting the medication, right? So it was really designed to answer that question. And people have gone back and then looked at like the 50 to 59-year-old age group and tried to sort of to get the data out from there. And even when you look at those groups, the benefits are not there to recommend it as preventative therapy. Because you have to also remember when we're talking about the 13-year, 18-year follow-up, we're talking about 5 years or 7 years of drug now with 13 years of observational data afterwards, right? So might people change their behaviors because they were given a drug that at the time they thought was harmful? So, we just have to be careful about what we say we know for sure based on that.
But I guess it would be from that, what you just said, we don't really have a trial with the modern preparations in women who are within 10 years and 60 years old, from menopause. We don't have a real prospective randomized trial, right?
Well, we do. We have Elite was oral estradiol, I believe, and then we have Keeps, which was a different dose of Premarin. I think it was 0.45, and then it was transdermal. 50 microgram patch. So we have two actual studies that use more modern hormone regimens, and they didn't find any benefit from a cardiac prevention standpoint or from a dementia standpoint. And we also have, the long-term follow-up data from that. I mean, people make a big deal about ELITE, but the change in CIMT, carotid intima media thickness, was really minute compared to what we see with statins. And, that's a secondary outcome measure anyway. So yeah, we have those data, and they don't show this massive benefit. And I think it's really important for people to understand that there's such a massive healthy user bias with menopause hormone therapy. So all of the older observational data that showed benefit, when you go back and look, these tend to be healthier users at baseline. They tend to have more money. They had to have a higher education level. And there was a recent, really interesting observational study published in Denmark just last year that showed that women who used menopause hormone therapy before the WHI had a lower all-cause mortality. After the WHI, people who used menopause hormone therapy had the same all-cause mortality. And in fact, the women who'd switched from systemic to vaginal, they had the lowest all-cause mortality, and those are the ones that had the highest education. And so it would suggest that a lot of the older observational data is really confounded by all these biases that we know to be true with health outcomes.
Okay, I'll accept that. Now, the other trials you mentioned, though, are much smaller than
Mhm.
WI or the arm of the estrogen alone, the 10,000. So
Mhm.
I admit that certainly they're randomized and helpful. And I know you rely on that type of strong, hard evidence. Now, let's do a lightning round of some organs of the body. Okay. Bone.
Uh-huh. Yeah, so menopause hormone therapy has absolutely been shown to reduce the incidence of fractures. I think in the WHI, it was 5 per 10,000 per year, if I remember that accurately. And I think it's important. I mean, it's a lightning round, but it's important to look at somebody's underlying risk, right? So if you're somebody at very low risk for osteoporosis, is that something you're going to need versus very high risk?
Yeah, now that's actually one of the things I was going to get to in just a minute, which is why don't we partition risk for these conditions more? But okay, so and by the way, when we go on this lightning round, tell us if there's any difference in your views regarding combination therapy or estrogen, whether it's local or systemic alone.
Okay.
Okay, so bone, I think we all would agree there's some benefit in
Oh,
people,
absolutely.
women of risk of osteoporosis. Heart disease, heart attacks, heart, as you say, atherosclerosis.
Yeah, we don't have any data to show that there's benefit for that.
Okay. Clotting, like DVT, pulmonary embolus.
Yeah, so definitely oral estrogen is associated with a 2 to 4-fold increased risk of clots. In the Women's Health Initiative, it was twofold for the younger women between ages 50 and 59. For transdermal, we don't have good long-term randomized trials comparing it with oral. The observational data would suggest that there's no increased risk, but there's always an asterisk because it's observational data. And also, I would say that most observational data is probably with a 50 microgram patch equivalent. And so when you start using these higher doses, that I don't think we have an answer for that.
Okay. Cognitive benefit.
Yeah, we have no data to support cognitive benefit from menopause hormone therapy. And this has been reviewed in detail at the last two menopause society meetings by Dr. Pauline Mackey. And so it's an active area of research, an active area of study, but people should not be starting it because they believe it's going to protect them from dementia.
Okay, good. Diabetes, insulin resistance.
Yeah, the data is also not really very good. And it's from the WHI that we have it, and that's oral in one form of oral that we don't use. And the difference is really quite small. And if you look at what you could achieve with exercise or diet or other things, you're going to see a far greater improvement.
Okay. Now, before I ask about the next one, let me just review. So, in the mouse model, if you take an old mouse and you put in young mice ovaries, you extend lifespan. But now, I also, of course, the former director of AHRP, Renee, who you probably have interacted with, she wrote, the only organ in humans that we just accept to fail is the ovary. And of course, there's been so much consternation about health span. What are your thoughts on that?
Yeah, well, my good friend Lauren Stryker just left a question: "Women are not mice." So I think that's a really important thing. Mice have estrus, and women have a menstrual cycle. Mice are meant to breed until they die, right? And women evolved very differently. And if you look at the history of our evolution as a species, women had 20 years post menopause where they were contributing to society. I mean, if you look at the wise woman hypothesis, which is the idea that women in menopause basically help drive evolution because they were there to provide assistance to their own children and their grandchildren. And that being healthy and being active, doing all of that actually was what drove our longevity as a species. So yeah, I think when people talk about ovarian failure, to me, that means that they have a very poor understanding of kind of the biology of ovulation and the biology of, a menstrual cycle versus estrus. And yeah, we're not mice. Mice can tell us a lot of stuff, but it's all preclinical work. And we have to then apply that to humans. And this idea um, that that ovaries are like die and they're deficient and they stop working is also not true. So the postmenopausal ovary is still contributing to the pool of testosterone, for example. So I think that we should be careful how we're talking about things.
Because some of the anti-aging companies are thinking about rejuvenating or extending the life of ovaries in the years ahead in humans, of course. So that's why I asked you that question. I mean, it's all speculation whether it could be achieved, whether it be safe, whether it be worthwhile. I think
Yeah. I mean, I think that, none of these people ever talk about the negatives, which I always like to say. So, for example, when women sort of approach their late 30s, early 40s, their incidence of two conditions, adenomyosis and fibroids, starts to increase dramatically. And, that is probably related in part to lifetime exposure to estrogens. And so what is going to happen to those uteruses if they're keeping getting exposed to sort of estrogen in their 50s and 60s and 70s, like from ovulation, not from menopause hormone therapy, which is a lower amount, right? And so I think that we just have to be super careful about the assumptions that we make and about the cherry picking and this idea that longevity is going to be expanded by expanding ovulation. I mean, you can't make new eggs. We're all born with what we have. And so what we can do is we can slow the eggs the idea is that maybe we can slow the number that are pulled out of the pool, but we don't know what the long term, we don't know if that has any long term implications or not. So I just think we need to be like really careful about jumping to conclusions, or what I like to call, wishful hypotheses.
yeah, no, that's great. The immune system is something, as you know, we can't measure in the clinic. And the only place it can, up until now, be measured was in academic labs with, various T and B cells and interferons and antibodies and sequencing of the T cell, B cell receptor. Anyway, it's very convoluted and difficult. But the discovery of organ clocks, which includes the immune system, has been interesting because in a big study and now replicated by others, by Tony Wiscori and Stanford, they found that the immune system in those women who were taking estrogen shifted to a younger immune system clock. That is, the pace of aging was slowed. It's not a randomized trial, you know, but it's an interesting point because it's something we haven't been measuring in the clinic. Um, I mean, as something to watch. I don't know if you want to make any comment about that, but the immune system does seem to be important as a driver of healthy aging.
Yeah, I mean, but also, we know, for example, that people who exercise robustly have a better survival for cancer. So
Right.
right, so when we start to look at the health disparities with, people being able to get access to healthcare and get screening, and when you're starting to study the immune system of people, a non-randomized sample of people who are taking menopause hormone therapy, you're taking an incredibly biased part of the population. So I just think that we have to be really careful without true randomized data, especially looking at the health disparities in this country, about jumping to any kind of conclusions.
In a full agreement. Okay, now let's move. But before I go into the partitioning of risk, you mentioned that your practice of the use of MHT hasn't changed over the years. And I suspect, the way it was pre-WHI was that some approximately 30% of women were getting um, MHT. And then it dropped down to, less than 5% after the black box warnings and all this stuff. And in fact, I've had many patients, Jen, who've come to me in my cardiology clinic, women that said they can't get MHT from their gynecologist, won't give it to them because of all these risks. And I said,
Mhm.
"What?" So you haven't changed over these decades, of how you use, I mean, you maybe the different preparations, but
Yeah, I mean, I would say that, when I say I haven't changed, I mean, if you're coming in and you have symptoms, I'm going to get, and you're at low risk. So, you're not somebody who, for example, just finished treatment for breast cancer 6 months ago. So, talking about people who we would consider to be a good candidate for menopausal hormone therapy. If you've got hot flashes, I was giving it to you before the WHI and I was giving it to you afterwards because, I kept up to date with the data. The Menopause Society came out with statements pretty soon afterwards. I thought about, okay, well, who are the people I trust in the space? What have they written about it? And so, I think that the problem is, especially in the United States, it's such a weird litigious environment. So this is an anecdote not related to menopause hormone therapy, but I think it really goes to show the difference. So I trained in Canada, put in, I don't know, hundreds of IUDs during my residency. I can't count how many. And when I moved to the United States, there were doctors at the University of Kansas who had never placed an IUD. They were
mm,
told in their residency it was too dangerous, that it would cause lawsuits, that women could get injured. And so I'm just like, what are you even talking about? Like, oh my God. So
yeah,
I just think that, there's a vastly different vastly different system. I think it's very easy when you think about how we deliver healthcare in this country. And this actually is true in Canada too. Primary care is reimbursed very, very poorly. And so when people come to the office and you have a long discussion about menopause hormone therapy, you get almost no money for that. So it's very easy for people. And I'm not saying this is an excuse, but as to view it in kind of context. So if you're a residency and you're trying to get everybody trained, office space is what you think people are going to learn after. And then they don't
yeah,
because it doesn't reimburse. And so I think it's really an indictment of the training system and how everything, that sort of model, if you will. And it's not an excuse. And I'm not saying it's an acceptable reason for people to have not stayed up to date. But I just think that, if primary care were reimbursed differently, we might be in a different situation.
absolutely. I'm sure you're right about that. Now that this black box has been lifted, perhaps not substantiated by the actual data, and perhaps not with a real review. It was a cursory review, not a formal one. What's your projection? Is it now going to become back to where it was pre-WHI, where 30% or whatever more of women postmenopausal will get replacement, get hormone therapy?
Well, I think, as I said, like before the WHI, we were giving it to people we shouldn't be giving it to. I mean, there were women literally starting in their 70s and 80s. So I don't think we can actually say, like, what's the true percentage of people who should be on it. Lots of people have hot flashes. Lots of people suffer. Should all those people who are safe to get menopause hormone therapy have access to it? Absolutely. You know, I if the black box never really changed anything that I did because I explained it to people in advance. And I like to point out, I prescribe a lot of treatments that have black box warnings, and Dr. McCary is not concerned about any of those. I give tons of topical tacrolimus for lichen sclerosis. Haven't seen him interested in that. I think vaginal clindamycin has a black box warning for C. difficile, if I'm not mistaken. Haven't seen anybody be interested in that. And so, I think it behooves us as providers to explain the black box warning, what that means and doesn't mean to an individual patient. I don't think the black box warning is going to change things. What I think is going to change things is propaganda and financial investment. So there are companies that you can go and get menopause hormone therapy from. You can basically fill out a questionnaire. You can, not give them your mammogram. And it seems people are getting it. And I'm like, you didn't tell them you have a blood clotting disorder? No, they didn't ask. So I think that when we have, Instagram and TikTok and all this content going out to people and, influencers with massive followings saying that menopause hormone therapy has been proven to reduce dementia, which is not true,
Right.
that we're going to see, a surge in people using it. And we just, I don't think that's going to be based on the black box warning. It's just those things have happened at the same time.
Yeah, no, that's very helpful, kind of putting that in context because the information flow or misinformation is coming from lots of different directions now, as you're pointing out. And we're going to get to wellness in a minute. But before we do that, you actually touched on something, which is where you said a risk of, for example, blood clots. And then there's, women who have risk of breast cancer, and there's women with risk of uterine cancer. And
Mhm.
we don't do any polygenic risk scores or assess people at risk for osteoporosis or any of these things. We could do those. That is a formal genomic assessment, which is really inexpensive. And we just go by their history. Did they already have a blood clot or did they already have breast cancer? Can't we do better in separating out those people who are at risk so that we don't um, unknowingly treat them and induce a problem?
Yeah, I mean, I think that the problem is we don't have perhaps the best way to screen people. So, for example, the current recommendations from the U.S. Preventive Services Task Force, which, they're always very conservative, right? Because like
Oh,
they're all
yeah.
methodologists. So, right? I mean,
Right.
so, and I appreciate that. I think it's really important that we have like a super conservative one side so we can say, okay, let's look at that, but we should, so we can look at everything in total, right? So the U.S. Preventative Services Task Force doesn't recommend starting screening for osteoporosis until age 65, unless there's risk factors. And I think what happens
Even
is,
DEXA scan for $75, anywhere. And
well,
no,
I think, the thing is that first of all, there are many people that we catch just by asking them about risk factors. So whether you even, so we can do a FRAX score in the office. We can look at somebody's weight. There are so many ways. So what I would say is there's all this low hanging fruit that, if I see somebody who's 52 and thin and they told me they had an eating disorder between the ages of 20 and 30, and I ask about that because if people had eating disorders when they're putting on their peak bone mass, that can affect their bone mass. Yeah, you bet I'm getting a DEXA for that person. Absolutely. I don't need a polygenic risk, anything to tell me that. I know that patient's at a high risk. I
right.
need to,
There's going to be thin people, never had extra weight, who are really prone to osteoporosis too.
it's one of the biggest risk factors. Absolutely. And I think that we need to do a better job of figuring out who should be screened earlier for osteoporosis. And unfortunately, the lack of data then gets translated by the U.S. Preventive Services Task Force as, well, we shouldn't do it. Okay, well, lack of data doesn't mean we shouldn't do it. Lack of data means we need to figure out how to do it.
Yeah, so instead of the U.S. Preventive Task Force, like, for example, at Mass General Brigham, they're giving patients in their health system these polygenic risk scores, like for breast cancer. They're giving it, and for heart disease. And, you have twofold risk or you have no increased risk. Wouldn't that be helpful in general if those were widely available?
So, but I don't know how well those actually pan out long term. Like, I think that, like, so for example, I'm a participant in the Wisdom study, and they gave us a polygenic risk score. But when I talked to a genetic counselor, I mean, they're now studying, trying to decide what does that actually mean long term in the incidence of breast cancer mortality or breast cancer diagnosis or breast cancer screening. So I don't know that we have like the long term data to say what some of those risk scores actually mean. I mean,
Well,
I could be wrong, but I mean, from a breast cancer standpoint, I don't think we can tell people that it can raise or lower your risk, but we can't speak in absolutes.
no, I
So
think your point, just to clarify, if you have a high polygenic risk for a condition, it doesn't say when. You could have a high polygenic risk for Alzheimer's, but it could be manifest at age 99. That doesn't really help you.
right.
So
Yeah.
but I think we have increasing confidence after all these years, decades now of these, that they can be helpful, but they're not being used. And certainly they're not going to be recommended by the preventive task force for the reasons that you've already mentioned. Now, another big issue is how long do you use the therapy, MHT? The rest of a person's life? What do you say there?
So I would tell people that we do not have the long-term data to answer that question. So it comes back to like in everything in medicine, we need to individualize. So what is the reason you're taking it? And what are your underlying risks? So for example, if you're taking combination therapy, so an estrogen plus a progestogen, we think that there's data to say that progesterone gives you a lower risk of breast cancer, but we don't know for sure. The observational data is actually conflicting. So I think it's best to go with the fact there is probably an increased risk. The actual percentage, we probably don't know. WHI is 28%. So if you take somebody who has a lower underlying risk of breast cancer and somebody who has a higher underlying risk of breast cancer, that 28% might mean different things to those people. And so I think it's important to have that discussion. It's also important to have the discussion, what's their risk of osteoporosis? What's their risk of endometrial cancer?
Right.
So, and that's a really, really important thing because most of the data tells us that progesterone is not as good at preventing endometrial cancer as the progestins, but the progestins may be associated with a higher risk of breast cancer. And so it's really important for us to individualize what for that individual person. And so what I say for people who want to stay on it long term because they feel better on it, something that hasn't been quantified in studies, I would say the best thing is probably for you to be on transdermal because your risk of clot increases with age. So your risk of a blood clot at 50 is not the same as your risk of a blood clot at 75, right? And so probably transdermal is safer. And probably the lower doses are safer because these higher doses that we see a lot of people on now with transdermal, these aren't things that have been captured in any studies except the primary ovarian or premature ovarian insufficiency data. So, if somebody's on a 25 or 37.5 microgram patch long term, there's, we probably have we have very little data to say that would be something that's harmful. And if somebody feels better, then that's a reason to do it. But also if someone says, I'm low risk of osteoporosis, I took it for 6 years, I don't have any hot flashes, I want to see if I need it for hot flashes, I'm going to support somebody coming off too. I'm going to support them in either direction.
All right. So what if you have a woman who's, let's say, 12 plus years from menopause, never been on
Mhm.
D, and would like to take a patch for whatever benefits it might be gleaned? Would you say, oh, go ahead?
So I would need more information. I would want to know what benefits she's hoping to get from it. Because if it was for cardiac prevention or dementia, I would say, well, there would be no reason to do that. And I would say that, based on WHI and based on KEEPS, which we have, good long-term data on, that we could say that the risk of starting menopause hormone therapy in the 60s might be slightly elevated from a cardiac, might not. It's kind of on the border. In the 70s, for sure. The risk for dementia starts to increase around the age of 65 from the data that we get. So if I have somebody who's 61, who's been struggling with hot flashes for 10 years, and she could, when she went through menopause at 51, and she couldn't get any doctor to prescribe it for her, and she's at low risk from a cardiac standpoint, of course I'm going to offer that woman a patch. If she's telling me she wants to take it to prevent dementia, and that's the only reason, I'm going to have a different discussion because I'm going to say, this isn't going to do that for you.
Yeah. No, so everything needs to be individualized. That's a theme here.
Yeah, but that's,
Well, that's
medical
medicine.
care in
But
general, right?
hey, this is one of the most complicated things in medicine, Jen. I'm glad you're on it, but with all the different variables of the preparations, combinations, the risk of the person that you're talking to, the time duration, the time lapse from menopause. There's so many, complexities and nuances here. That's why, there aren't enough clones of you out there with the information at hand, and there's lots of, information that's kind of off track. Now,
Well, I
now,
just like to say there's lots of amazing, menopause providers out there and lots of people doing a really good job. And I would say the Menopause Society does a really good job at distilling, the best of the evidence. And I'm just going to put a plug in for ACOG has a book coming out, I think in January or February, written by like the true giants in the field. So,
oh, well,
so if
good.
you're, yeah.
That, oh, now right now we're seeing big resources from philanthropists, going into women's health, and obviously this is part of it, um, and not just menopause, perimenopause, premenopause. I mean, all things women's health, which is great since this has been an area that is mixed up and had some miscues. What are your thoughts about that?
Well, I think that it's hard since I don't know all the specific ways the money is being given. I would just say that one thing that we're missing a lot of in women's health is good basic science research. So that that I would like to see more money go for that because it's really hard for us to say. So, for example, we don't know why people get endometriosis. We really don't. We have such a poor understanding of this disease that affects 10% of women. And we don't have any disease modifying drugs for endometriosis. When I started medical school, Crohn's disease was awful and terrible, and people had surgery after surgery, and they were on massive dose steroids. And now we have disease modifying drugs for these people. And you know what? Endometriosis can have all of the same awful healthcare ramifications. It affects far more people. And we still like know very little about it. And so I would say that we're really behind the eight ball. And many of these underlying conditions like endometriosis also have long-term impacts on health. It's not just the awful, terrible things women are going through at the time, but also many of these conditions are associated with, for example, earlier menopause and other sort of, inflammatory changes in inflammatory markers. And so I just hope that as we're seeing sort of this renewed interest, that we're not sort of looking more at like niche things and we're thinking like, hey, we actually have like polycystic ovarian syndrome. We still also have quite a poor understanding of that. Affects again like 10 to 12% of the population. So I just think like we also need to make sure that we're putting money in what seems like unsexy to people, like actually funding the labs that are trying to figure out, how these things are not just affecting women at the time, but also long term. So, for example, we know that women with polycystic ovarian syndrome, much higher risk of many of them much higher risk of diabetes later in life, higher risk of cardiovascular complications. So understanding these things earlier on will also pay off long term for women.
Well, speaking of PCOS, polycystic ovary syndrome, we've seen all these so-called Ozempic babies on GLP-1. That is a treatment for PCOS. Any comments about not just that drug, but the whole family of drugs in use in women?
So, I'm not an expert at all in medical treatment for weight loss. My colleagues who are tell me these are great medications and for the right person are a fantastic drug. And so I just have to, trust my colleagues who have done that research. I would say that we do know that excess weight makes many aspects of PCOS worse for women. It is not a cause. Absolutely not a cause, but it can be an exacerbating factor. And so helping women with that can absolutely improve ovulation. And so we're going to definitely see, I'm glad to see that for people who desire to be pregnant, that they're getting that outcome. And for people who don't desire to be pregnant, I hope that their doctor's talking to them also about, highly reliable contraception, so that, we're seeing the people who want to get pregnant, and the people that are not, are not. So yeah, so I know very little about the medication, so I just like to, defer to the experts there.
Sure. No, I get it. I'm glad you can have limits of your of where you're would consider your expertise or knowledge base. Now, why I would do want to talk to you about this wellness initiative out there. This term is now very difficult. Wellness. I don't know what it means anymore,
Yeah.
but you kind of already touched on it there. That there's all these companies that you can connect with, that you can get, MHT. You can get all kinds of supplements, all kinds of claims about things that have no data. Tell us what your thoughts about this, because it does appear that women are being targeted specifically. Uh,
Yeah.
yeah,
Yeah. So first of all, I like to be really clear. You can get bad care in the office and you can get preyed on in the office and you get good care in the office. And that same thing can happen online, right? So we have people that are, putting in hormone pellets and people that are doing all kinds of procedures that are, not supported by the evidence in the office, right? And then there's people who are prescribing with the Menopause Society guidelines. And so we have that disparity. And I think that we see that same thing with telemedicine. We see some telemedicine companies that are, you know, taking insurance and they're basically, doing exactly what the guidelines say and they're prescribing within the bounds. And then we see places that seem to start that way, but now have supplements and now have compounded weight loss, GLP-1s, and oral weight loss drops and medications for your adrenal gland. And so, the money, as I mentioned before, if you could make a fortune prescribing menopause hormone therapy, then you wouldn't need the VC money to set up your clinic, right? You'd be making it hand over fist. So how do you make the money hand over fist? You make it by scaling up. You make it by offering products that are very cheap for you to make and sell. And supplements in the United States are one of them. I mean, I set up a fake supplement just to see how much I could make. And with a couple of emails, I just had to sell over 8,000 bottles to make $200,000. So if you're talking about a company now that has generated this massive mailing list, right, based on their menopause hormone therapy, based on all these types of things, and now you're getting these ads every day in your mailbox for their weighted vest or for their sleep supplement or for their adrenal booster, don't tell me that's not going to lead people to buy it. And so that's just, it's very difficult to have buyer beware. And I think in this age of propaganda, people also have to realize that the first piece of information that you see is the one you're most likely to believe. So if you use this company and they gave you what you wanted, menopause hormone therapy, and now they're telling you they have compounded estrogen face cream or they have adrenal support supplements, why wouldn't you believe them about that?
Right, right. Well, speaking of wellness industry, one of the major forces in that, Dr. Casey Means, may be the next Surgeon General. Has there been any concerns that you had about her past and then becoming the Surgeon General?
Well, I actually know very little about her. I mean, I'm trying to protect my mental health as much as possible from this administration. So, I mean, my understanding is that she's not board certified and that she's got all these encroachments, financial entanglements in wellness companies. And I guess, if I was, writing a novel and I said that was who I was putting up for the attorney general, I'm sure my editor would say that's just not believable. Nobody would do that. So, who do I want? I want people who have, you know, either a rigorous background in clinical care, that they're a 25-year clinician who has been in the trenches doing the work, or I want somebody who has done the research. I want someone who has really actually contributed to science in a way that if you surveyed, 100 people in the profession, they would all agree that that's a major contribution. So I just think that all of these financial entanglements are very concerning. And, the problem with somebody like the Attorney General is that they have a megaphone. If they say something, all of the media is just going to pick it up.
Surgeon General.
And yeah, and then Surgeon General, sorry, yeah. And so then, so then what? We're left in the office yeah, I know you heard that this adrenal support supplement is going to cure you being tired, but let me tell you, it's probably the fact that you're only getting 4 hours of sleep while you're tired. And let's talk about that. And I think one of the big problems with wellness is it offers seemingly simple answers to very complex questions,
Right.
right? And it distills things down in a way that sound truthy, but aren't truthful.
This is what gets me is that the evidence is so absent for all these things, the supplements and all the things that you mentioned, but they're marketed to the hilt. And, right now, for example, there's TV ads for microdosing GLP-1. There's not a single paper about,
Yeah.
we don't even know what that is.
Right. Yeah. There's no definition for it.
Yeah. So along your lines, your point about that we need to invest more into the science, basic science, understanding these issues in women's health. The NIH cut $14 million from the Office of Women's Health. That's not a good thing.
Yeah, no, I know, right? So think
Yeah,
about it. Think about you've got Marty McCary doing his press tour for Health and Human Services talking about, oh, we did this great thing. We removed the black box. Oh, by the way, we've gutted research. you know? So I'm always a cynic, and the timing is always very interesting to me. But yeah, it's, we were supposed to have, there was supposed to be a big menopause conference at the NIH in December that, and it's, been canceled because of the lockdown and everything. And the loss of, I'm sure the loss of staff has contributed to it. So, so it's great lip service. And I just think that I want to get back to one point you mentioned about these wellness companies and promoting things like microdosing or adrenal supplements or the sleep supplement. When I see that, to me, that is the ultimate in misogyny, because you are saying that women do not deserve the science, that
Mhm.
we're going to sell you, we're going to make money from you, and we're going to do some smoke and mirrors about the data to make it look like it's research backed when it's not. So what that tells me is you think women don't deserve science. Because yeah, it takes a while to understand things and to make sure that we can do it safely. So when you jump ahead of the queue, that tells me that you don't think women deserve that. So
Mhm.
that's what I would like everybody watching to think when they see these products that are promoted. We're like, we don't even know what microdosing GLP-1, like there's no even definition. So if
Right.
there's no definition, how do you have a product,
Well,
right?
that's what gets me is when people are hawking things like this, supplements and other drugs, if you will, um, they immediately lose their credibility. Because if you're really an expert in this field, why are you doing that? That's there's something wrong with this picture. Now, there is a new drug, a neurokinin, that is supposedly has dramatic effect for reducing hot flashes. Can you tell us about that? And is that how would you incorporate that into practice?
Yeah, so we already have one fizzolinate, I think that's how you pronounce it, that's on the market, and that's a neurokinin 3 receptor antagonist. And then we have this new one, I think it's Elizonate, but I can't, the naming is awful,
Liz?
which is a neurokinin 3 and 1 receptor antagonist. And
Yeah.
basically, the part of your brain that's involved in generating hot flashes uses neurokinins. It's the candy neurons. And estrogen has an impact on that. And so do the candy neurons, so this neurokinin receptor system. And so this is a different entry point into treating hot flashes. And the data looks pretty good. And this new product, the new one, works on both neurokinin 3 and neurokinin 1 receptors versus the old one just worked on neurokinin 3. And so this is a great option for people who can't take estrogen, who don't want to take estrogen, who don't like how they feel on hormones, because there's a significant percentage of people who don't like how they feel. And so it's a great option, but it also unlocks a lot of research doors for us. Because the problem is when you give a drug and say, for example, you're giving estrogen, well, there's estrogen receptors throughout the body. So if you're getting benefit, why is it really? But if you're just giving a drug that only treats one part of the brain, then maybe that would allow us to kind of see, is this a benefit from estrogen, or is this a benefit from helping people sleep? Is this so it really opens up other doors, because we do have some data looking at non-hormonal methods and how they kind of have an impact, on cognition and things like that. But so we need more agents so we can actually have a better understanding. So it's really exciting from a research standpoint too, because when you think about the cumulative effect of not sleeping, right? So when you're looking at someone going through menopause, or is somebody in early or late menopause transition who's not sleeping well, we don't know, when people are suffering, how much of that suffering is actually due to lack of sleep and how much of it is due to other things. And so being able to kind of target in other ways really opens a lot of research opportunities. So it's really exciting.
Yeah, no, that's great. We have something really positive with hard data, randomized trial, and another.
Yeah.
So that's good. Now, um, overall, you've mentioned about some disenchantment with the administration. Of course, I share, and you've also recently, some weeks ago, I guess, announced that you're going to move back to Canada here. Are they linked, or is that just something you've been wanting to do, leave the United States after 30 years of being a treasure chest of information and expertise in this area?
Yeah, it's I've wanted to move back to Canada for some time. I'm kind of homesick in ways that's hard to explain, but I would, you know, I would say that the administration has maybe moved things up,
Mm.
and it's more so the fact that I write about a lot of things that could make me a target, and I think about that. And I'm a naturalized US citizen. And I think about what if the law changes about that. And so I'm weighing my risks and my benefits. And, none of my children are going to be living in the United States. And so, you start to think about, you're sort of the whole sort of your sort of the wealth of all the information. And so, yeah, so I would say that the administration and everything that kind of moved it up, but it was always kind of in the cards. And I think that what it's done, I was kind of hoping to kind of go back and forth, have my summer place and my winter place and kind of go back and forth. And I think the administration has changed things, and I'm, really kind of eyeing, have really a lot of thought about the impact of politics on women's health in general. And I've tried to make a difference one-on-one in the office, and I've tried to make a difference by writing and disseminating information. And now I'm really thinking about, how I might be able to make some kind of difference politically.
Well, Canada's lucky to get you back next year, for sure. But I hope your writings in the agenda of Substack and also your books. I don't know if you have another book in the making, but you're such a great writer. You don't hold things back. As I said before we got started, you're really a great truth teller in this field. So, are you going to keep up with the Substack agenda and also write another book?
Yeah, I mean, so I love learning. The thing that I love the most is to read a paper that's written about something that is new or that I didn't really know about. Even if it's not like, so I read things that aren't always in my field just because I'm interested in it. I love going, my one of my favorite things is to go to a lecture by an expert in the field that has like nothing to do with what I do and just listen to them like hold court in their expertise in the literature. So yeah, I'm going to keep writing because it's like I love reading new articles. I'm like, I'm going to be writing about, I alluded to this article earlier from Denmark that looked at changes in all-cause mortality. And I don't know, I missed that when it came out last year. And then, the fire hose of data, right? And so, yeah, I love writing. I love learning. And so, yeah, I'll continue to do it, and I'll continue to be writing because, it
We're
keeps
counting
me busy.
you for that, Jen. Now, before finishing, did I miss anything in this general field that you want to bring up? We covered a lot of ground, I know, but is there something that we should have delved into?
Yeah, well, I think that it's one thing that I would like to two things I'd like to say. First of all, the guidelines from the Menopause Society and the Australasian Menopause Society has fantastic guidelines too, are up to date. And so when people are telling you they're not, I would recommend going and double checking there. Use that as your sort of source of fact checking. They have documents that are very easy to look at. But I would also say that specifically for people in the United States, that there is so much about this administration that is doing so many awful things for women. And to think of removing the black box from estrogen as some kind of win for women is really a smoke and mirrors. I've just told you that we should be able to explain that to people, and I get that we can't. But the problem is it's not that the black box warning, that removing it is a big thing. What should have happened was that we should have looked at systemic versus oral versus systemic versus vaginal. We should have looked at drugs by class. In every other medication, we don't just say, oh, all of estrogens. We look at, we're going to say like all of immune drugs. We like look at them by class, and we have class specific warnings. We should be doing that for estradiol, for conjugated equine estrogens, for the different progestins. And so what I would say was, this whole thing with a black box warning, to me, seemed to be all about a PR move and not about what actual people who prescribe hormone therapy and people who study it would have actually wanted. We would have all welcomed an actual real panel process where we sat down and we said, how can we sort these out? What do we know about vaginal? Let's focus on that first. Then what do we know about the different types of systemic treatments? Should we have different class-based, different warnings and not have a single class? We would have all welcomed that. And so instead, what we got was this press tour that was presented as a win that really isn't. And then I would say to people, we're going to start seeing things probably about SSRIs and pregnancy. And then what about mifepristone and medication abortion? And they've talked about looking at contraception.
Right.
And so once you say that it's a win to ignore the system and ignore what the scientists are saying, then you've opened the floodgates for everything else to be damaged and destroyed and taken away from you. So I just think people need to be very aware. I've always been concerned, as my friend Lauren Stryker, who I think has been watching, she's a menopause physician as well, that the press from this is going to be used in such a way to sort of soften these other things that may be coming. And so I just think we need to have constant vigilance.
Of course. The only thing I'd say about that is because the prescriptions had gotten so remarkably low, less than 5% zone, and people don't keep up with the literature like you. Maybe even though a lot of things were wrong here, but maybe kind of a changing a position will help get it back to where it should be, the field. Maybe a thought on that is, it's like the right conclusion for the wrong reasons, or, you know what I mean, is there so many gynecologists were not giving women like you are, whether it's different preparations or for the, really drilling down into the individualized rationale. They weren't doing it. So, I mean, the data suggested that it was like a taboo thing for so many gynecologists throughout the country. Maybe this will help. What do you think?
Well, the problem is it came with a healthy dose of lies and propaganda,
Yeah.
right?
No,
So
I
that's the problem, is that it wasn't just, they didn't just say, okay, we're going to take the black box warning off because it doesn't suit the current needs. And then we're going to revisit it and figure out what it does suit. They could have done that, right?
right.
But what they did was they said it's been proven to reduce all-cause mortality. It's been proven to reduce dementia. And so the thing is, and then what does the press pick up on, and what do people pick up on? So I would say that you have to, that I don't really consider it a win, because it's not just a thing that happened in isolation. It happened with this propaganda, piece in the Wall Street Journal, and propaganda on the news, and propaganda in JAMA. That was like an embarrassment to read. So I would just say that, if the person who wrote that editorial is making decisions, like, that's pretty bad.
Well, that's why I highlighted those statements from the Pearl and JAMA in the opening of our conversation, because they were I would say, hyper exuberant, of course.
Yeah. And I
But
would just say that, like, we had a process for doing this the right way.
yeah,
And it was a choice to abandon that. And then what does that mean then if we can abandon it for one thing? What else are we going to abandon it for? And I'm looking at it this lens of erosion of abortion. And we have now right-wing forces telling women that contraception is unsafe. And so I'm looking at it in this greater lens of women's health care. And so I just think that sometimes you have to be careful what you ask for, because sometimes you get it, right? Like,
yeah,
that's, yes, one of those kind of lessons from fairy tales. So I just think that they could have done it. They had a choice to do it in a way that I think many people would have said, oh, okay, that's like a win. That's doing, that's a good thing to do. They had a choice, and they didn't take that choice.
right. Well, the context you're providing here is important, of all the assault on women's reproductive rights and so many other things that are going on right now. The anti-science, whether it's, Tylenol with pregnancy, or autism and vaccines. And, so there's an anti-science. There's also, I think what you're bringing up is a process of the science, that this was, really off kilter. Uh,
Well, I mean,
yeah,
I just want to add one more thing. We have a lot of this process in place because women have historically been harmed by people just making decisions, right? Like, we have all this history of things that have been understudied and given to women, or women being coerced into having tubal ligations or not even knowing they were going to have it before. So we have all this process like as part of protection. So what happens when we start abandoning that,
Right.
that?
Right. Well, I am with you. This has really been a great review, Jen. I think you got a lot of things straightened out that hopefully some of the folks that are listening, watching, it didn't answer all the questions. There were a lot of good things in there. Sorry we couldn't get to everything. There's everything from, red light and, so many other things in there. Oh, we covered a lot of the stuff. And, thank you for all that you've been doing over these decades in the US. We will continue to follow you next year when you move back home. And, some people will be envious of your immigration, but we'll be reading your writings and hopefully having more future chances to interact like this. Thanks so much. I really enjoyed being with you today.
Oh, thank you so much for having me. And thank you everybody for joining. It's always a great conversation. And thank you again for having me.
Great. Okay, stop there.